Doctors from around the world volunteered to participate in an unusual experiment.
What I'm doing now is being manhandled by these people who are doing some sort of neurocognitive testing.
The task at hand, the future of surgery.
This is a very original thinking.
It's called the Surgical Metrics Project. Here, surgeons underwent a bit of biohacking.
I was curious. I wanted to see what it was all about.
Over the course of 3 days in the exhibit hall, 253 surgeons performed a common operation. But before they picked up their forceps, each doctor was outfitted with a bevy of wearable technologies.
This is definitely not typical operating room attire.
The devices will measure their surgical decision-making, as well as their technique, as to why.
The goal of this project is really to bring new and fresh data to what we do as surgeons on a daily basis.
The brains behind the operation, Stanford trauma surgeon and educator Dr. Carla Pugh. Digital data is her domain.
It's the future. When you look around us, all of healthcare is now becoming digital. Surgeons need to be part of that conversation.
Pugh is an international expert on the use of sensors and motion tracking technology. She wants to help surgeons by quantifying their experience.
If you want to be the best that you can be, getting there is much easier when you have data.
The experiment begins by measuring a surgeon's brain activity. Technicians attach a wearable EEG to the forehead. The doctor then takes a cognitive test.
We had to do a test of our attention and memory.
The EEG's role
Is to get a baseline of the cognitive abilities of the people, and then we want to compare that to their performance during the operation.
The team then puts motion tracking capture sensors on the surgeon's fingers. The hands get gloved and the wires cabled to a control unit.
Once you get into it, you kind of relax and forget that you've got wires on your fingers.
The patient, it's actually a small piece of a pig's intestine, punctured with tiny holes. You may perceive. The surgeon must first find and then repair the damage. They have 20 minutes.
That's perfect.
2 small video cameras record the action as the surgeons work. The sensors capture the surgeon's hands moving in 3D. The EEG sends the doctor's brain waves to the cloud. All sound is recorded and the data synced up.
I was rushing.
When time's up, a photo is taken and water pumped through to see if there are any leaks.
I didn't leak.
It was perfect.
The data is now waiting to be crunched. The surgeons all see a benefit.
It's very useful in training.
I think it's really important.
There are surgeons that are better than others, but we don't really have any way of checking that.
How do you match up so that you can then improve your skills till you get to the level of the expert?
Or have a way, at least for residents and training physicians, to be able to test their skills.
It's important to make sure that as we age, that there is some kind of true data measurement.
The Surgical Metrics Project will collect more data next year at the Surgeons Convention in Chicago. In San Francisco, Juliet Goodrich, KPI X5.
This was a huge study. We had 1,600 square feet. We had 10 operating room tables with pig intestines. The participants came and did surveys, they put on wearables, and they repaired some intestines. And we had 255 participants. We were shooting to get over 200 for the attendings, which are experienced practicing physicians. And then we allowed some of the residents and retired surgeons to participate when the exhibit booth had open space. But our goal was to really enable them to develop metrics, talk about the metrics, and work with us to have some data-inspired policy around being able to have this type of data. There are policies that are already existing that protect surgeons' ability to capture video from their operations and other procedures, but as the data expands, so the policies need to be expanded as well. This is a picture of a wired clinician with all the wearables that you see here. And what they had to do was look through the bowel. This is a piece of pig intestines. Sorry for those who don't like blood and intestines. But they had to find these two lesions, and they weren't as easy because this is what they look like. The smaller one was difficult to find, and those who missed the smaller one only repaired the larger one. And then when we did the leak test, they leaked right away. This is a successful person whose bowel repair was done, and they did not have a leak. But when we looked at all of the practicing clinicians and some of the residents where we had 100% video and no data loss, we did lose some of the data with video or the wearables. But 200 people, over 200 people, most of them did not leak, but some did. We wanted to look at those who didn't leak and those who were efficient. So tier 1 gave us those who were extremely efficient in their repair but didn't leak. What we noticed was that tier 1, those that are in green are the ones who did not leak. Those who were in blue did leak. And what we noticed was that those who did not leak, they actually spent more time on the repair than those who leaked. It's still interesting that this group of people spent more time than the Olympians, if you will, but they still leaked. And so there's some interesting metrics to be found in terms of their strategy. Similar in terms of the idle time, what we notice is in all of our work, when the idle periods actually is when you're doing your operative planning. And so we noticed that not only did those who didn't leak spend more time in the procedure, but they actually had more idle time, meaning they were more thoughtful in planning their next steps and then going on to execute it. The path length was longer, meaning they actually did more work. It's just very interesting. Separately, those who were in the more efficient group within their leak or no leak group, they were not as jerky in their movement. They were more smooth and calculated in what they were doing. So very interesting, both with their right and their left hand. So if we were to develop a haptic score for the bowel repair Olympians, it would include time metrics, velocity metrics, and GPS metrics. And again, really wanting to allow an opportunity to quantify what it is that those persons who are at the top of their game, the most expert clinician in terms of their strategy and their movement, that we make this data fully available, such that you do have a benchmark. Right now, we don't have it in surgery or in healthcare. And so it's just interesting that one of the most important professions where you still use your hands, whether you're manipulating a robot or a surgical tool or doing an exam, we don't have an instant replay. The thing that we want to see, like when that, critical moment happened in a game, we get instant replays. We don't have that in surgery. At best, we can get a 4-hour video and nobody wants to watch that. This technology actually enables us to combine the data from the wearable technology with videos and really make AI analysis of these videos more efficient so that we in the medical profession can have instant replays. I would love to search Google for an instant replay of that moment that mattered and not get a list of videos that are an hour or 2 hours long. I only want the really important information. So when I think about the future of wearables in medicine, it definitely is getting data on the physician side in addition to the patient side. And obviously the combination of the two will just take us even further with respect to healthcare. But for the practitioners, I believe that there will be everyday use of this and it will be protected because it relates to quality, and that's where the policies from a legal perspective stand right now. And that it would just vastly improve information exchange and the research that we were able to do. Many times, ironically, most people think that when a procedure doesn't go well or a diagnosis is missed, that it's because of the skill of the clinician. What we're finding in some of the research, especially during the idle times, when we go back and look at that period of the video, we're finding that some patients have anatomy that doesn't allow for the standard routine. So we'll get a better mapping of the skill of the clinician as well as the anatomy of the patient that's presenting difficulties in terms of giving certain levels of efficiency and accuracy. Again, we think this data will greatly facilitate AI. Some people are trying to use AI to analyze surgical videos, and it's very difficult because it's out of context in terms of the full choreography of what a practitioner is doing. So This is my team. Again, please contact any of us if you have an interest in developing technologies and partnering with us. We have lots of collaborators on campus and in industry, and we're looking for more. We are definitely focused on making a difference in healthcare and new discoveries. So thank you so much, and I look forward to any questions.